I request Dr. Tarannum, Professor Tarannum, to join us on the podium. She'll be speaking on anti-VEGF, stubborn H in Vernal Keratoconjunctivitis, an update.
Good evening, everyone. So I will be talking about the stubborn itch of vernal keratoconjunctivitis. And we all have been seeing cases of VKC on a day-to-day basis. And what is new? Advances in the understanding of the complex immunopathology underlying VKC has fueled the development of new treatment options. Clinical forms we all know, but most of the signs and symptoms of VKC, they overlap with other forms of allergic conjunctivitis, like seasonal, perennial, atopic, and giant papillary conjunctivitis. So we need to know when it is VKC that we are treating. Intense photophobia and ocular pain, they are specific for VKC. Also, when the regular treatment for allergic conjunctivitis and the patient is not responding, then also we should be suspecting that it might be a case of VKC. And a definitive diagnosis requires the presence of limbal or tarsal papillae. Ineffectively treated VKC can of course leads to all the corneal complications. And more importantly, it's the quality of life of the patient and that of the parents that is significantly and profoundly affected. So, pathogenesis, initially it was described as just an IgE-mediated disease. But 50% of the patients did not exhibit any allergic sensitization despite being the involvement of the immune mechanism of allergic conjunctivitis. So this also explained why just the regular anti-allergics, topical antihistaminics, and mast cell stabilizers alone used to fail to control VKC. So now it is recognized as a more complex disorder that involves multiple immune mechanisms like overexpression of mast cells, Th2, eosinophils, and a range of inflammatory cytokines and chemokines. Diagnosis, mostly it's the clinical presentation, which is good enough, but for borderline cases, a marker that appeared to be more specific for VKC diagnosis was histamine tear levels. Also, we can go for ocular cytology, and an invasive investigation like conjunctival biopsy should be reserved for cases which are exceptionally atypical. Treatment of VKC revolves around both pharmacological and the non-pharmacological measures. When I talk about non-pharmacological, it is identifying the allergen and reducing the exposure to the same. It is not an easy task by any means, but certain behavioral rules have been recommended, like avoiding the itchy eyes, the rubbing the eyes that should be avoided as much as possible. Exposure to sunlight, wind, salty water, dust, heat, all should be avoided. An air filtration system in the home that may also provide relief. Then frequently washing the hands, face, and hair, and thus washing off the allergens, that also helps. Cold compressions, preservative-free artificial tears that can also dilute the allergens. And most importantly, when it comes to behavioral rules, adhering to the treatment is very, very important. Pharmacological armamentarium includes both approved as well as off-label drugs. Symptomatic relief can be provided by mast cell stabilizers, antihistaminics, and NSAIDs. Mast cell stabilizers, for that we have cromolyn sodium, nitrochromyl sodium, naga, and lodoxamide. When these were compared in various studies, it was seen that topical lodoxamide was fared better over cromolyn sodium in decreasing the signs and symptoms of the disease. Similarly, nitochromyl also, as compared to cromolyn sodium 4%, achieved significantly greater reduction in itching, grittiness, hyperemia, and keratitis over a period of 6 weeks. Antihistaminics, now we have certain recent generation of selective H1 blockers that have better tolerability and longer duration of action as compared to their first generation counterparts. Still, symptomatic relief, though rapid, the duration of effect is very short, so frequent instillation is required with these antihistaminics as well. So to counter these limiting factors, now we are having these dual acting agents, which is like combined antihistaminic and the mast cell stabilizing properties. Olopatadine was the first to be approved by the FDA, followed by bipotestine, azilestine, and alcaftidine. Cost factor might sometimes be there with these agents. Topical NSAIDs, they are helping by inhibiting the release of the pruritogenic prostaglandins, but their corneal toxicity is very significant and is documented, so should be judiciously used in patients of ocular surface disease. When we talk about immunomodulators, topical steroids are going to top the chart, and needless to say, we are all aware with the adverse effects as well. So always starting with the low potency steroids, followed by high potency only when we are not able to achieve the desired clinical effect that should be done. One modality of installation of steroids which is definitely underutilized is the supratarsal steroid injection, because it has been seen in a lot of case reports that severe VKC, which was refractory to both topical as well as systemic steroids, they responded to supratarsal corticosteroid injection. So this is one modality of treatment which should be looked into. Then we have steroid sparing agents like calcineurin inhibitors, cyclosporin A and tacrolimus. They have now long history of off-label use with very good efficacy in the treatment of moderate to severe VKC. When we talk about cyclosporin, the cationic emulsion in 0.1% is now approved in various countries for use in VKC, but the very significant side effect is the instillation site pain and pruritus. Tacrolimus, on the other hand, available both as drops as well as ointment. It has been approved in a concentration of 0.03% for children 2 to 15 years of age suffering from VKC. Comparing the two compounds, the two drugs, that's again a very, very commonly asked question. Comparative study have yielded mixed results, and as far as comparison of tacrolimus with cyclosporin A cationic emulsion is concerned, there have been no head-to-head studies so far. Allergen-specific immunotherapy, that is exposing the patient to the allergen through gradually increasing doses over time. It's a very long-drawn process and may take months to years. But yes, it does reduces the need for topical as well as systemic medications. When I talk about emerging therapies, IgE blockade is topping the chart in the form of omalizumab. It is not only targeting the IgE-mediated mechanism, but also the non-IgE-mediated mechanism. And case reports have shown very encouraging results, and the treatment was well tolerated. Reduction in steroid use as well as enhancement of quality of life was seen with this particular drug. But yes, long-term trials are required for the same to get its official approval for the use in VKC. Leukotriene inhibition through montelukast is again a very safe drug, is still underutilized because in patients with comorbid asthma and VKC, where it was used, it used to cause significant reduction in the ocular signs and symptoms. And as compared to mast cell stabilizers, it fared much better. So this is again a very underutilized drug. We should be using it more often because it's a very, very safe drug. So despite all the developments in the understanding the histopathology of the disease and the pathogenesis as well as the newer treatment options, the challenges persist. It is the heterogeneity of VKC which makes it very difficult to develop a global algorithm to treat VKC, and also adherence to behavioral modifications and complex treatment regimes is actually a challenge not only for the patient but also for their caregivers. So take-home messages from my side. Patient education and non-pharmacological interventions are equally important when we talk about treating VKC. Timely diagnosis and customized treatment options should be customized for each and every patient. Omalizumab may serve as a promising treatment option for VKC due to its ability to target both IgE-mediated and non-IgE-mediated pathophysiological pathways. And a validated quality of life measure such as a quick questionnaire, if we incorporate that in the treatment plan, that could be of help. Thank you for your time and for your patience.